Welcome to the deep dive. Today we're tackling a really important area, women's health.
Absolutely.
We've gathered a set of, well, really interesting medical case studies that cover a huge range.
Yeah, everything from vulvar issues, puberty, ovarian masses.
Endometriosis, changes in the uterus, even ectopic pregnancies. It's quite a spread.
It really is.
And our mission, so to speak, is to pull out the key knowledge from these scenarios. Like, what are the core things to understand about these conditions? What factors might be involved?
And maybe most importantly, what are the essential steps in figuring things out and managing them? Drawing out the essential threads, really.
Exactly. Grasping the fundamentals from these real-life situations, how they show up, the logical path for assessment.
And care, yeah.
Okay, let's dive right in then. First up, something that can be, well, incredibly bothersome and cause a lot of anxiety, vulvar issues.
Uh,
We have a case here, a postmenopausal patient. She's dealing with chronic vulvar itching, hasn't really responded to over-the-counter stuff, and now she's noticed a new raised lesion.
okay.
Understandably, she's worried. Thinking about cancer, infection, what immediately comes to mind?
Yeah, her concerns are totally understandable. When someone comes in with vulvar itching or pain or a mass, we sort of mentally categorize the possibilities.
Like a differential diagnosis.
Exactly. You've got dermatologic conditions,
Yeah.
things like lichen sclerosus, which causes thinning, itching, or even just simple irritation from soaps, that kind of thing.
Okay.
Then infections like yeast, maybe herpes. And importantly, we have to consider neoplastic changes, precancerous or cancerous cells.
Right.
And finally, there are benign things, like simple cysts. The tricky part is similar symptoms can point to very different causes.
And this patient, she has a few things in her background that might be relevant, right? Clues, maybe?
Absolutely. Being postmenopausal is a big one. Lower estrogen levels can change the vulvar skin, make it more fragile, more prone to irritation. The chronic itching itself can kind of set up a cycle of inflammation. We also know she has diabetes.
How does that play in?
Well, diabetes can affect how the body fights infections, and sometimes it's linked to skin changes too. And then there's the long-term estrogen deficiency from menopause. That's another piece.
So if you're the clinician seeing someone with these complaints, what are the absolute must-do steps in the evaluation?
A really, really thorough exam is key. Good lighting, careful visual inspection for subtle changes.
Looking closely.
Yes.
Mm.
And palpation, feeling the area for any lumps, hard spots. You need to document everything carefully, maybe even take photos to track changes.
Okay.
Checking the lymph nodes in the groin is standard. Sometimes we might use a colposcope, basically a magnifier, for a closer look at the skin. STI testing might be on the table, depending on the situation. But here's the critical point. Any lesion that looks suspicious, ulcerated, thickened, pigmented, needs a biopsy.
And in this specific case, the decision was to immediately biopsy that small, firm plaque she described. What's the rationale there? Why biopsy right away?
A biopsy is the only way to know for sure what's happening at the cellular level. It tells us if it's benign, infectious, precancerous, or actual cancer.
It's definitive.
Exactly. Generally, if a vulvar lesion hangs around without a clear reason,
Huh.
especially for several weeks, you biopsy. Any weird color changes, sores, thickened areas, or spots not getting better with initial treatment, they all raise a red flag.
Makes sense. Now, given this patient is older, maybe a bit frail, are there other things to consider around the biopsy itself?
Definitely. Her overall well-being is important. Managing pain during and after the procedure, for sure.
Right.
It might also be a good time to think about screening for common geriatric issues, fall risk, cognitive changes, that sort of thing.
Looking at the bigger picture.
Yeah, assessing her functional status, her home support, and crucially, talking with her about the treatment goals, making sure her preferences are central. Plus, practical advice on gentle vulvar care. Moisturizers that can help manage irritation too.
Okay, good points. Let's pivot now to a completely different stage. Puberty. We have a case involving primary amenorrhea, a young patient who hasn't started her periods yet. This can cause a lot of worry for the patient and parents. How do you approach that initial conversation?
Yeah, it's a common concern, and reassurance is key initially, alongside gathering info. Primary amenorrhea means no period by age 15 if she has developed secondary sexual characteristics like breasts and pubic hair normally.
Which this patient apparently has.
Yes, the case notes say she's developed appropriately in those areas.
Yeah.
Tanner stage 4 to 5, which is an important positive sign right off the bat.
So what are the first practical steps? What tests do you usually order?
First thing, always rule out pregnancy. Even if it seems unlikely, you check.
Standard procedure.
Absolutely. Then we look for underlying medical issues affecting hormones. Initial blood tests would include TSH for thyroid function, prolactin.
Why prolactin?
High prolactin levels can suppress the menstrual cycle. We also check FSH and LH, the main hormones controlling the ovaries. And a pelvic ultrasound is really important to confirm the uterus and ovaries are actually there and look normal. And of course, scheduling a follow-up to discuss results is crucial.
Can you quickly run through the typical sequence of puberty in girls? What usually happens first?
Sure, typically the first visible sign is the bonnish breast bud development. That's usually followed by adrenarche pubic and underarm hair. Then comes the growth spurt, the peak height velocity.
Right.
And finally, menarche, the first period, usually happens about 2.5 years after breast development starts, often around 10 or stage 4.
So when that sequence doesn't quite happen or menarche is delayed, like in this case, what are the possible reasons? What's the differential?
It's quite broad, actually. It could just be a constitutional delay. She's a late bloomer, basically. Very common, usually benign.
Okay.
Or it could be hypothalamic amenorrhea, often seen in athletes or girls with very low body fat, where the brain signals get disrupted.
Stress or energy related.
Exactly. Then there's hypergonadotropic hypogonadism. The ovaries aren't responding properly. Think Turner syndrome or other genetic conditions affecting the ovaries. The opposite is hypogonadotropic hypogonadism. The problems with the signals from the brain. Kallmann syndrome is an example, or maybe a pituitary issue.
Okay.
Sometimes there's an outflow tract obstruction, like a imperforate hymen blocking flow, or Mullerian agenesis, where the uterus or vagina didn't develop properly.
Structural issue.
Right. And finally, endocrine disorders we already mentioned, like thyroid or prolactin issues, or even chronic illness can interfere. So it's a systematic process of elimination.
Wow. Okay. Lots of possibilities.
Yeah.
If those initial tests, TSH, prolactin, FSH-LH, don't give a clear answer, what are the next steps?
It depends on what those first tests show. If FSH and LH are really high, it strongly points to the ovaries being the problem.
Ovarian failure or dysgenesis?
Correct. If FSH and LH are low or inappropriately normal, it suggests the issue is higher up in the brain or pituitary. Estradiol levels tell us about estrogen production. If we suspect a wider medical issue, maybe a CBC or inflammatory markers, and imaging ultrasound or sometimes MRI gives us that crucial anatomical picture.
What if the hormone levels are actually normal? FSH, LH, estradiol all look okay. What does that suggest?
That's what we call eugonadotropic eugonadism. It means the hormone signaling seems okay. So then you really focus on anatomy.
The outflow tract again.
Exactly. Pelvic ultrasound is key to look for Mullerian agenesis absent or underdeveloped uterus. If there's any hint of a central nervous system issue, an MRI of the brain pituitary might be needed.
And chromosomes.
A karyotype, yes, especially if uterine agenesis is found, to rule out disorders of sex development, like having XY chromosomes but appearing female.
Got it. Now, just quickly on the flip side, what about precocious puberty? What is that and why is it a concern?
Precocious puberty is puberty starting unusually early before age 8 in girls. The most common type is idiopathic central precocious puberty. The brain signals just switch on too soon for no clear reason.
And the concern?
Well, a couple of things. Early fusion of growth plates in the bones can lead to shorter adult height. And there can be significant psychosocial issues, feeling different, teasing, body image concerns, maybe early sexualization. So counseling is important. And sometimes treatment with GnRH agonists to pause puberty is considered.
Okay, thanks. Let's switch gears again. An incidental ovarian mass found unexpectedly, maybe on imaging for something else, in someone with no symptoms. What's the first move?
The immediate next step is usually a good quality transvaginal ultrasound. That's the best way to characterize the mass.
Simple versus complex.
Exactly. Is it just a fluid-filled sac with thin walls, a simple cyst? Or does it have solid bits, thick walls, internal structures making it complex? Might also check a CA-125 blood test.
The tumor marker.
Right, but you have to interpret it carefully, especially in premenopausal women where it can be elevated for benign reasons. For simple cysts below a certain size in premenopausal women, we often just watch them, see if they resolve.
And complex cysts.
Complex features usually warrant surgical evaluation, regardless of age.
How does the approach change if the patient is postmenopausal?
The index of suspicion is higher after menopause because the risk of ovarian cancer increases. For complex or solid masses, prompt surgical exploration is generally the rule, pretty much regardless of size.
Even for small, simple cysts.
Even small, simple cysts in postmenopausal women need careful consideration. Sometimes they can be monitored with repeat ultrasounds and CA-125 levels if they're small, and the CA-125 is normal, but surgery is often considered more readily.
We have a case here, a 6-centimeter complex ovarian cyst. What kind of things are on the differential diagnosis list for that?
Okay, a 6-centimeter complex cyst could be a few things. It could still be a functional cyst, though they're usually simple. An endometriosis cyst often looks complex.
Right.
A tubo-ovarian abscess, an infection, but that usually comes with pain, fever. Benign ovarian tumors like cystadenomas or teratomas can look complex.
Dermoids, yeah.
Right. And then, of course, a concern is malignancy epithelial ovarian cancer, or maybe a germ cell or sex cord stromal tumor.
This particular patient, her mother had ovarian cancer. How significant is that history?
A first-degree relative, like a mother, definitely increases her lifetime risk. It doesn't mean she will get it, but it raises the index of suspicion, especially with a complex mass. It pushes towards a more thorough evaluation and likely surgery.
Are there specific symptoms, if they were present, that would make you more worried about ovarian cancer?
Yes, some symptoms are considered red flags, though they can be vague. Things like persistent bloating, feeling full quickly when eating early satiety, urinary frequency or urgency, pelvic or abdominal pain or pressure, maybe finding a mass yourself. In later stages, you might see weight loss, fatigue, fluid in the abdomen ascites.
Okay. Let's shift focus now to the uterus, specifically the lining, the endometrium, and postmenopausal bleeding.
Right, postmenopausal bleeding is always considered abnormal until proven otherwise. It needs investigation.
This case involves bleeding 2 years after menopause. And she has several other notable things in her history.
Yes, the history is really important here. Significant obesity, never having been pregnant, nulliparity, a later age of menopause, a history suggesting irregular cycles before menopause.
Suggesting anovulation.
Exactly, likely periods of unopposed estrogen exposure. Plus, she has diabetes and high blood pressure. It's quite a constellation of factors.
What are the main possibilities when a postmenopausal woman bleeds?
Top of the list, the most serious concern is endometrial cancer, or its precursor, endometrial hyperplasia.
Okay.
But more commonly, it might be due to atrophy thinning of the endometrial or vaginal lining from low estrogen. Endometrial polyps are also common, or fibroids.
Less common causes.
Less often, it could be related to anticoagulants, hormone replacement therapy if she's on it, or even rarely, something from the cervix.
We often hear about unopposed estrogen driving endometrial cancer risk. Can you break that down, especially with this patient's history?
Sure. Estrogen makes the uterine lining grow. Progesterone, which normally comes after ovulation, counteracts that growth and matures the lining.
Keeps it in check.
Right. Unopposed estrogen means the lining is getting stimulated by estrogen without that progesterone balance. This can lead to overgrowth hyperplasia and eventually cancer.
And how does her history fit?
Well, her obesity is key fat cells produce estrogen. Her likely history of anovulatory cycles means less progesterone. Late menopause means more years of estrogen exposure overall. These all contribute.
So pulling that together, what are her biggest risk factors for endometrial cancer specifically?
Her obesity is probably number one. Then the inferred history of unopposed estrogen from anovulation and late menopause. Nulliparity is also a risk factor. And her diabetes and hypertension are associated with increased risk too.
So when a patient like this presents postmenopausal bleeding, these risk factors, what are the next diagnostic steps? How do you investigate?
The first step is usually a transvaginal ultrasound. We specifically measure the endometrial thickness.
The endometrial stripe.
Exactly. A thick stripe, say over 4 or 5 millimeters in a postmenopausal woman not on HRT, is concerning. But the gold standard for diagnosis is an endometrial biopsy.
Taking a tissue sample.
Yes, ideally done in the office. It's usually well tolerated and gives us tissue to examine microscopically. If the office biopsy isn't adequate or results are unclear, then a hysteroscopy looking inside with a camera and a DNC might be needed for more tissue.
And if the biopsy does come back showing carcinoma, what's the management plan then?
The cornerstone of treatment for endometrial cancer is surgery, usually a total hysterectomy removing the uterus and cervix, plus a bilateral salpingo-oophorectomy removing both tubes and ovaries. Often, lymph node assessment is done too, either removing some nodes or doing sentinel node mapping to see if cancer has spread.
Saging surgery.
Precisely.
Yeah.
The pathology from surgery gives us the final FIGO stage. Based on that stage and other tumor factors, adjuvant treatment like radiation or sometimes chemotherapy might be recommended.
Obviously, treating the cancer is the priority. But what about those other health issues, the obesity, diabetes, hypertension? How important is addressing those?
Oh, incredibly important. Treating the cancer is step one, but addressing her overall health improves surgical outcomes, long-term survival, and quality of life.
Right.
So definitely weight loss counseling and support, optimizing her diabetes control, getting blood pressure well managed, smoking cessation if she smoked, making sure she's up to date on vaccines and other health screenings, maybe referrals to nutritionists, exercise programs. It's a holistic approach.
Makes complete sense. Okay, let's turn now to endometriosis, a condition known for causing significant pain and impacting fertility.
Yes, endometriosis is where tissue like the uterine lining grows outside the uterus and the pelvis usually.
Mm.
Symptoms can really vary, but often significantly impact life quality.
This case has symptoms like worsening period pain, chronic pelvic and back pain, pain with bowel movements,
Petitgasia, yeah.
difficulty conceiving, maybe an ovarian mass, suggesting an endometrioma, and a family history. That sounds pretty classic, doesn't it?
That cluster of symptoms is highly suggestive, yes. Progressive dysmenorrhea, chronic pain, pain with specific functions like bowel movements, infertility, plus the possible endometrioma and family history. It ticks a lot of boxes.
But what do we actually know about why endometriosis happens? What are the theories?
It's still not fully understood, probably a mix of factors. The leading theory is retrograde menstruation. Menstrual tissue flows back through the fallopian tubes and implants in the pelvis.
Okay.
But that doesn't explain everything. Other theories include coalomic metaplasia cells lining the pelvis, transforming into endometrial cells, or Müllerian rests leftover embryonic cells developing.
Interesting.
There's also spread through blood or lymphatics. And increasingly, we think altered immunity and genetic predispositions play a significant role. Some women are just more susceptible.
How do you actually diagnose it? Is there one definitive test?
The only truly definitive diagnosis is through surgery, usually laparoscopy where you directly see the implants. Taking biopsies of those implants confirms it histologically.
Seeing is believing, essentially.
Pretty much. However, we often make a presumptive diagnosis based on classic symptoms, especially cyclic pain responding to hormonal treatment and imaging findings, like seeing an endometrioma on ultrasound or MRI.
Are there ways to stage or classify how severe it is?
Yes, a couple of systems are used. The Revised American Society for Reproductive Medicine, RASRM score, is common. It stages from I minimal to IV severe based on the size, location, and depth of implants and the presence of adhesions. There's also the Enzian classification, which is better for describing deep infiltrating endometriosis, focusing on specific locations like ligaments, bowel, bladder.
And what about treatment? What are the options?
Treatment is very individualized. It
Yeah.
depends on symptom severity, desire for pregnancy, age, extent of disease. Medical options aim to manage pain and suppress the lesion.
Like birth control.
Yes, hormonal contraceptives, pills, patch, ring, progestins alone, like pills or the LNG IUD. For more severe cases, GnRH agonists or antagonists to induce a temporary menopause. Sometimes aromatase inhibitors, and enzymes for pain, of course.
And surgical option.
Laparoscopic surgery is common, excising or ablating implants, removing endometriomas. For severe disease, especially if fertility isn't desired, hysterectomy with removal of tubes and ovaries, BSO, might be considered, though it's a major step.
Anything else?
Adjunct therapies are important too. Diet, exercise, physical therapy for pelvic pain, counseling, and definitely fertility consultation if pregnancy is a goal.
Okay. Lastly, let's tackle a critical emergency, ectopic pregnancy.
An ectopic pregnancy is when a fertilized egg implants outside the uterus, most often in the fallopian tube. It's a potentially life-threatening situation.
If someone presents an early pregnancy with bleeding and pain, ectopic has to be high on the list, right?
Absolutely. It's a diagnosis you cannot afford to miss.
What else could cause those symptoms, though? And are there specific clues pointing towards ectopic?
Other possibilities include a threatened or ongoing miscarriage, a ruptured ovarian cyst, even appendicitis or a UTI can sometimes mimic it. Ovarian torsion is another one.
Okay.
Clues that raise suspicion for ectopic include a history of a previous ectopic, history of PID or tubal surgery, pain that's often one-sided, specific tenderness on exam, especially cervical motion tenderness.
Are there known risk factors? And what about the patient in this scenario?
Yes, definitely. Prior ectopic is a big one. History of PID like chlamydia, which can damage tubes, previous tubal surgery. Using IVF, smoking also increases risk.
In this patient?
This patient has two major risk factors, a prior ectopic and a history of PID. That significantly increases her risk.
Where do most ectopics happen, and are there rarer spots?
The overwhelming majority, like 95–97%, are tubal, most often in the ampulla, the wider part of the tube.
Mm-hmm.
Less common sites in the tube are the isthmus or fimbria. Even rarer sites include the ovary, the cervix, or the interstitial part of the uterus where the tube joins. Abdominal pregnancies are very rare.
So when someone comes in with bleeding, pain, early pregnancy, what's the very first test?
You confirm pregnancy first, usually with a urine test, but crucially, a quantitative serum Bode-HCG blood test. That gives us the actual hormone level.
Okay, HCG level obtained. What next to figure out if it's ectopic?
The next key test is a transvaginal ultrasound. We're looking for an intrauterine gestational sac.
Inside the uterus.
Right. There's something called the discriminatory zone in HCG level, usually around 1500, 2000, above which you should see an intrauterine pregnancy if it's there. If the HCG is above that level and you don't see a sac in the uterus, you're highly suspicious of an ectopic.
What if the HCG is lower?
Then it might be too early to see on ultrasound. So we often repeat the HCG level in 48 hours. In a normal early pregnancy, it should rise substantially, roughly double. A slow rise, plateau, or fall suggests either an ectopic or a failing intrauterine pregnancy.
Any other helpful tests?
Serum progesterone level can sometimes help. Very low levels are more suggestive of a non-viable pregnancy, whether ectopic or miscarriage.
Once you've diagnosed an ectopic, what are the management options?
3 main paths: medical, surgical, or rarely expectant management.
Medical first?
Medical management uses methotrexate, a drug that stops the rapidly dividing cells of the pregnancy. It's usually given as an injection. It's an option for stable patients with relatively low HCG levels, often under 5,000, no fetal heartbeat seen in the ectopic, and who meet other criteria.
And surgery?
Surgery is usually laparoscopic. Options are salpingostomy, removing the ectopic but trying to save the tube, or salpingectomy, removing the entire affected tube. Surgery is needed if the patient is unstable, bleeding internally, has contraindications to methotrexate, or if the ectopic is large or has ruptured.
And expectant?
Expectant management means watching closely without active treatment. It's only for very select cases where the HCG is already low and falling, the patient is totally stable and understands the risks. Requires very close monitoring.
Are there situations where methotrexate just isn't a good choice, even if the HCG is low?
Yes, definitely. If the patient can't reliably come back for follow-up blood tests and monitoring, that's a major barrier. Certain medical conditions like significant liver, kidney, or blood disorders are contraindications. Breastfeeding is usually a contraindication.
Practical issues, too.
Absolutely. Inability to follow restrictions like avoiding alcohol, folic acid, lack of quick access to emergency care if things go wrong. Social instability can also make the close follow-up needed for methotrexate difficult.
Wow. This has really been a comprehensive deep dive across such a wide range of women's health topics.
It really has. It underscores the complexity, but also how much we can learn from these individual scenarios.
Yeah, looking at these cases helps extract those key insights, the symptoms, the risk factors, the logical steps for evaluation and treatment.
Exactly. And it really highlights how vital it is to seek timely medical attention when you have concerns. Don't wait.
It does make you think about how interconnected everything is, doesn't it? And how much knowledge is constantly evolving in women's health.
Absolutely. Continuous learning and research are key.
Well, if anything we've talked about today resonated with you, or maybe raised some questions about your own health, we really hope you'll feel empowered to talk openly with your healthcare provider. That's the most important step.
Definitely.
Thanks so much for joining us on this deep dive. We'll catch you next time.